Thank you, Ron. It's a pleasure to be involved with this webinar. So I've been from Milwaukee, Wisconsin, and I've been doing spine surgery since 1987. So lots of things have changed over the years as a result with what we do with a spondylolisthesis, which is one of the more common problems that we see. So here's a model of your back. And so with a spondylolisthesis, what happens is that one vertebra begins to slip forward on another. So I'm actually dislocating that. It's not what happens is you get deterioration of these joints back here. So it's a very common problem that we see. And then you get narrowing of the spinal canal where the nerves travel. So the spinal canal goes from being wide open like this to being narrowed. And that's when you start developing spinal stenosis, which is pain down your legs, numbness, tingling, sometimes weakness, etc. So it's a problem particularly prevalent in the aging population. It's actually more prevalent in women than it is in men. But it's probably the thing that we see a very much a lot of. And the treatment over the years has initially included therapy and injections, and then ultimately surgical management. And the reason, so the pendulum has swung many different directions over the years. Initially, what we did was just do a laminectomy, which is to take off the bone that's pinching your nerves. And that opens up the spinal canal, and people oftentimes did really well because it's relief of the leg pain that is what's so debilitating for people. But unfortunately, what happened is that sometimes that resulted in more instability and the vertebra would slip further forward. So as a result, we did a lot of fusions on patients. And then we started realizing that there was a problem with the fusion in that other levels would start to wear out. You'd fuse this level here, and then the level above could wear out or the level below could wear out. Now, sometimes that produced symptoms and sometimes it didn't. But the fusion required you to take, and I'll show you on this model here, what a fusion looks like. And you put screws and rods in people's back, and then you put bone along the sides of their spine. And then oftentimes you would fuse the interspace. And this had an excellent outcome for people. They had 80 to 90% relief of their leg pain. They oftentimes had really good relief of their low back pain in addition. But the problem that happened is you develop adjacent level changes, and those adjacent level changes may require future surgery. So about 2005, the TOPS device, which is right here, became available. And I was one of the first investigators with the TOPS device. We did it for about 5 years, comparing the TOPS fusion with a standard lumbar fusion here. And the problem, we ran out of money, hit the recession, and so the device was not available. We didn't complete the study. And then about in 2018, I think it is, or 19, we started the study again. And this time we were again comparing the standard posterior lateral fusion with an inner body fusion with the TOPS device. Now, both operations require one thing that really is the key to the operation, which is the laminectomy, to take off the bone that's pinching your nerves. And but the advantage that the TOPS device has is that it replaces these posterior elements and provides stability. The reason why we did a fusion on some patients is because of instability. And instability means that you can slip forward even further. So the TOPS device replaces these posterior elements, but it doesn't require a fusion because it stabilizes that segment and then allows motion in all planes, flexion, extension, rotation. So I've been a big believer in preserving motion in patients' spine because that's what it does historically. And the TOPS device also has the benefit of producing less stress on the adjacent levels. So those adjacent levels won't wear out as quickly as they do with a fusion. And hopefully that will reduce the incidence of requirement to fuse the next level up. Now, we don't have enough data yet to establish that the TOPS device results in less wear and tear changes. It takes about 10 years or so to collect enough data for adjacent level degenerative changes to make a statement. But the preliminary results suggest that it's not. But when we compared these two surgeries in a blinded manner, we found out that in all measures, from neurological improvement to reduction in back pain, to return to work, to return to normal function, we found that the TOPS device here was superior in all measures. So routinely, I have been, now the device was approved for use about almost 2 years ago now. And this is my primary recommendation for a patient who has a degenerative spondylolisthesis. Now, some patients won't qualify because this disc is so worn out. If the disc is really worn out and it's bone against bone, then there's really not much benefit to doing a TOPS device for motion preservation. But that happens not very commonly. And the question will become over time, how does this function? And my experience to date, I've had no revisions of this. I've had revisions of this. I just saw a patient that I had in the study the other day who came in to see me for her 4-year follow-up. Now, she randomized, which means that when we initially did the study, we looked at people who had, you either got this device or this device, and you couldn't choose, okay? And so what happened was this individual got the fusion at the L3-4 level. Well, now she's developing a spondylolisthesis at the level below. She's starting to develop leg pain, not bad enough at this point to do anything, but clearly the fusion has resulted in wear and tear changes developing at other levels and will require, probably in this individual, future surgery. So when we've looked back at the TOPS device, we've seen that revision surgery is less long-term for adjacent level changes. The surgical procedure itself requires a similar amount of time. It does, however, result in less morbidity. What I mean by that is that you have to do an incision about this long in somebody's back to do the surgery. You take off the bone in both operations, but you don't have to strip the muscles as much. And so what I've been seeing in these patients is they leave the hospital either the same day. Some could leave the same day, but most people leave the next day. They aren't waiting for something to happen. You are, obviously waiting for the incisions to heal, etc., but you're not waiting for a fusion to take place. And so that means they get better faster, they return to work faster, they can resume normal activities faster. And so I have seen that this device, the TOPS device, has been superior in all measures as compared to a fusion. So it's certainly my primary treatment measure for people who have a degenerative spondylolisthesis. Now, as time goes on, there will be probably other indications, but this has been the primary indication to date. So I have found this device to be very helpful in my management of patients who have spinal stenosis and in particularly a spondylolisthesis. Now, not everybody has instability and will require a TOPS device. And furthermore, there's also people who have such wear and tear changes from the spondylo that they're bone on bone and they're almost fused themselves, and they don't need to have the TOPS device either. So you have to exercise good clinical judgment when you decide which device or which procedure you're going to utilize. So that's been my experience with the TOPS device. I think it's an outstanding device. I think it provides another option for the spinal surgeon. I'm an orthopedic spine surgeon, and I think this device has been outstanding in its use to date. There are other devices that, this is the only device of its nature where it replaces the entire posterior elements. There are other devices that have been utilized that you can't do as much of a decompression. So they've been inferior to this device. So this is the only one that replaces the facet joints and creates stability and allows you to do a complete laminectomy. That's the key to the operation, to get rid of all that leg pain that an individual has. So that's pretty much my thoughts about the TOPS device. The biggest problem that we're running into now is getting insurance approval. It's approved by Medicare, approved by Medicaid. It's approved by some of the Medicare Advantage programs. The big insurance carriers like Blue Cross Blue Shield, et cetera, United Healthcare in our area, have been hesitant because they think it's still investigational, which it isn't. It's not investigational. It's been well studied. It's a superior device in our initial studies, and hopefully it will be approved by these insurance companies as time goes on. So at this point, I'd be glad to entertain any questions that people may have.
Right. So there are a bunch of questions in the chat group, so maybe I'll start reeling them off, and we'll try to get through as many as we can. So we have a patient who's about 45 years old, has rather aggressive hobbies, including riding dirt bikes and carrying a heavy pack on his or her back. Do you think this device is robust enough for someone who has who's very active?
Absolutely. I mean, I haven't placed any restrictions on any of my patients. As I said, I've had no revisions to date with this device. I think that no, I would have no qualms about letting a person do aggressive activities. I don't think that's a problem at all.
Okay. There's another patient who's a fit 67-year-old who had previous cervical fusions. The fact that this person has had fusions in the past in the cervical spine, does that give you any pause as to whether this device will be successful in the lumbar spine?
No, I've had patients who've had cervical fusions in the group of patients that I have taken care of. It would have no impact on whether or not the device was applicable for them. Again, the biggest issue is what is their diagnosis in the lumbar spine. So that would have no impact.
Okay. Someone else writes that they actually have a fusion at L5S1. Now they have problems at 4-5. Would you consider using TOPS adjacent to an existing fusion?
In the study, you couldn't have had previous surgery, so I don't have a lot of experience with that, but I do know that individuals are utilizing it for adjacent level, and I would have no problems in doing that. Again, depending on your diagnosis, sometimes you just have degenerative disc disease, and you don't need to have a device like the TOPS device. But sometimes, if you do have a spondylo, I would have no problems utilizing that device above a level of fusion. In fact, I think it would be beneficial actually to use this device as opposed to doing another level of fusion if you could avoid that, because as soon as you fuse 2 levels, then you've increased your stress even more for that 3rd level to wear out. And so you don't want to have a domino effect. So that's the nice thing about the TOPS device, is that you try to avoid that situation. Now, we can't do it at 5-1 because of the angulation that occurs when we try to put the device in by putting these screws in. So you can't use it at 5-1. So the device is really utilized for 3-4 or 4-5, which are the 2 levels that are most commonly involved in spinal stenosis and commonly involved with a spondylolisthesis, et cetera. So no, I'd have no problem doing it to adjacent level. And it would be actually probably superior because you don't have the increased stress that would develop degenerative changes at the level above that over time.
So how would you compare the recuperation time of a TOPS patient versus a fusion patient?
So when you do a fusion, typically in this model here, what you're going to do is you're going to put bone along the sides here. What I do is I take this bone out and I grind it up and I put it on the sides of the spine along with a material that stimulates bone formation. And then I do an interbody fusion, which is to take out this disc, go in from the back, and you put a cage in here. And so you're fusing the spine almost what we call circumferentially. Now, it takes time for the fusion to occur, and it requires the right biology from the patient. Some people won't fuse well, particularly, say, smokers, for example. They're at higher risk for them not to fuse. And that would we call a problem we call a pseudarthrosis. Now, sometimes a failure of fusion doesn't cause any troubles, but sometimes it does. And then years ago, we'd have more trouble with hardware failure and things like that. Now, back to your question of the difference, that when you just do this device, you're not waiting for a fusion. So when I do a fusion, I typically put a person in a brace. I kind of restrict their activities for the first 3 months, and they go through physical therapy. Whereas with the TOPS device, I get them mobilized right away. I'm not waiting for the fusion to take place. The screws here have some ingrowth in them to provide more stability as time goes on, but you're not waiting for anything. So people get better much quicker with the TOPS device. In fact, we have a hospitalist who has said many times that the patients who have the TOPS device have gotten out of the hospital a lot faster and with less pain than those who had a fusion. Again, because of the extra bigger dissection that has to happen in order to put to do the fusion. So yeah, you get better quicker. You don't have to wait beyond. I let them get back to normal activities within a month.
So there's a patient who has a 4 mm unstable spondy. And the question is, when do you go to surgery? When should a patient consider going to surgery in the face of having an unstable spondy, or maybe even someone who has a stable spondy? What do you recommend is the point where someone should consider surgery versus continuing to kind of bear and grin it?
Well, first of all, you start off every patient with physical therapy and exercise program because that oftentimes helps. Okay. Then the second step is usually steroid injections, because that can, again, buy some time depending on how much stenosis you have. So the real indication for surgery is how disabled are you? What can you do? What can't you do? This operation, the risk of this operation typically are, if you do a fusion, well, then it's going to be nerve damage, infection, failure of fusion, hardware failure. And usually about 80% of people do well. Okay. So the risk of the TOPS fusion, it is going to be failure of the device. I've never seen any of that. Early on, we had a squeaky one, and then that in the study, and that was replaced. Same risk as infection and then nerve damage. So the reason you do surgery is because you, the patient, say, I can't live with these symptoms anymore. They are debilitating. I can't walk any distances. I can't stand for prolonged periods of time. My leg pain is preventing me from doing activities. Usually there's not a lot of back pain involved with it, but sometimes the back pain can be debilitating too. So those are the indications that I see and I want my patients to have before I entertain surgery, because there are risks and benefits associated with this operation. Fortunately, it is a good one. I mean, there are operations on the back that are okay, and there are operations that are great. This is a very good operation and is a game changer for patients.
So there's a question from a patient who is kind of on the border between osteopenia and osteoporosis. What is kind of how do you assess bone quality, and where do you kind of draw the line on whether to operate on a patient with poor bone quality with TOPS or frankly with fusion?
I have never had a problem with getting a fusion, even in an osteopenic or osteoporotic patient. The instrumentation sometimes is an issue, but usually they will typically fuse if you do the fusion correctly and you expose the bone and you put in material that stimulates bone formation and utilize their own bone. So I don't really see the fusion as a problem. The problem sometimes is that it takes time for the fusion to take place, and sometimes the instrumentation can loosen or the instrumentation could break historically. But I haven't seen any instrumentation break for years. We've gotten better with our instrumentation system. So I would have no hesitation to do the TOPS device in a patient who has osteopenia, even in osteoporosis, because what you do with the TOPS device is that you want to sink these screws all the way down as far anteriorly as you can. Some people have talked about putting cement in here, which I've never done, because then you can't take the screws out. It's difficult to do that. But I haven't. I don't routinely get bone density studies on people, but it's something you could do. I wouldn't, if they were severely osteopenic, that might be or osteoporotic, excuse me, that might be a contraindication, but I haven't seen that.
As you know, in the study, the minimum age was 35. And there's a patient who's younger than 35. I don't know how old this patient is, asking a question about what about younger patients. I assume that this person is alluding to diseases like facet cysts as opposed to degenerative spondylolisthesis. What do you think about, what would you typically do for a patient who has a tall disc and a facet cyst that requires, fairly extensive decompression?
Well, first of all, you try injecting that facet cyst that you might, there's sometimes people that can drain the cyst and inject the cyst, and sometimes that's helpful. But if you needed to, one of the questions that I have always had is who's a better candidate for this device, an older person or a younger person? A younger person, because you can maybe save adjacent level changes much better than you can with a fusion. And older patients sometimes develop wear and tear changes very quickly. So it's hard to know who's the best patient, but I think both are very good candidates for the device. So a 35-year-old, I think would be a much better candidate for this type of device than a fusion, because again, when you fuse the spine, you're going to increase stresses at adjacent levels. Sooner or later, those adjacent levels will wear out. Now, just because they wear out doesn't mean they're going to cause trouble. Sometimes they wear out and they don't have any pain. That's the mystery of spinal issues, back pain in particular. So in a younger patient, again, depending on the level of the spondyle, if it's a 5-1, you can't do this device. If it's 4-5 or 3-4, you certainly can. And you would have to do the appropriate amount of decompression for the spinal stenosis or radicular pain that you might experience.
I know you touched on it before, but we see a few people are asking specifically if they have Medicare. Is this a good solution for Medicare patients, and will Medicare cover it from your experience?
From my experience, Medicare has been fantastic. They'll pay directly for it. Now, the other thing that happens with this device is nowadays is that you have to get your hospital approval in addition to have the device available. But my experience with Medicare has been straightforward. They approve it, and Medicaid the same. The Medicare Advantage programs have been, it's interesting that they would be, even though it's approved, but the way Medicare Advantage works is they restrict certain things, and that's how they operate. And but no, Medicare, my experience has been very straightforward with this.
So we have a bunch of patients who've talked or asked questions about multi-level disease. So assume you see a patient has 2 or 3 levels of disease. What are the different options that you see for treatment for those patients? Again, not knowing specifically what any one of these patients has, but from your experience, when patients come in and they have an MRI that shows up showing multiple levels of something going on, what ultimately do they undergo surgically?
So I think there's been a big, at least for me, I started out when I started out, people with back pain, we looked at their MRI scan, we showed a dark disc, and we said that's the source of your pain, and we did fusion, and sometimes we did 4-level fusions and 5-level fusions, and then what we found out is that those patients didn't do very well. They had residual pain. The hardware would sometimes break because it was early on. We weren't really, the hardware manufacturing wasn't as great as it is now. Obtaining a fusion wasn't as good because we didn't have, we had to take bone sometimes off a person's pelvis, which caused a problem. And we didn't have bone substitutes as good as we have now. So obtaining a fusion was more difficult. So my experience now with multi-level problems is I try to avoid fusions. I think that motion preservation is a better idea. I've been involved with disc replacements, both lumbar, cervical. I've been obviously involved with this device, and I think motion preservation is the key. So sometimes what you'll see is that somebody has adjacent level spinal stenosis that you have to deal with, but you can preserve the stability because you don't have to take off the entire lamina. You do the laminectomy, but you don't have to damage what we call these facet joints here. So it all depends on what type of pain a person is experiencing. If it's mostly leg pain and spinal stenosis type symptoms, you can just do a laminectomy and preserve the stability. And that works extremely well. If you have a multi-level degenerative changes for which they have spinal stenosis and back pain, well, sometimes you have to go and fuse multiple levels. I try to avoid that. I try to tell patients that I'll do your laminectomy to get rid of your leg pain, but you're going to have to do a great rehab program to get rid of your back pain. But if you have evidence of instability, then you may need to have a fusion or the TOPS device, depending on how many levels are involved, et cetera. So I'm just seeing a patient. We're not really talking about it at this webinar, but you can link this up with a fusion one level. So yeah, that's how I handle multi-level problems. I try to avoid a fusion if I can over all the levels, but sometimes I might just fuse one level. That, like if you had a degenerative spinal, but spinal stenosis at multiple levels, I would just do the laminectomy at multiple levels and the TOPS device at the instability, which would be typically 4-5 or 3-4.
I see some of the folks have done a little bit of homework and have seen some of the work that we do in Europe, where there's a combination of a fusion at one level and a TOPS at the adjacent level with some of the instrumentation that we offer in Europe that allows a hybrid procedure. So I don't know if you want to talk to that or kind of leave it unsaid, but as you said, go ahead.
No, I just saw patients the other day who I'm going to recommend that they have a slipping forward of one vertebra on the other at the 5-1 level. We call that a spondylolisthesis 2. And then he has a 4-5 spondylo at level, and he also has stenosis at 3-4. So that individual is looking at a 3-4 laminectomy and will preserve his facet joints. We'll do a 4-5 TOPS device and then do a fusion at 5-1. I personally have not done that procedure yet because I haven't seen it. Well, most of my TOPS patients that I have done to date were based on the studies, and that was not in the study. But now that this study is over and we are embarking on the device being available, the VersaLink is available. I think for Medicare or Medicaid. I'm not 100% certain about that. I think it is. And so that will be an option for some patients. So again, it's depending on what levels you have involvement in your spondylos and what levels need to be fused.
Last question here. Someone's asking, what's the longest TOPS patient you have? I know you're involved in the original study and then the new study. What are the longest patients you have from the original study?
Probably 20, probably 15 years. And when we did the original study, the first study, we compared the fusions, which did really well, and we did the TOPS device, which did really well. And none of those patients have come back to see me and required any revision surgery. So I think that the device has clearly shown. Now this device has changed a little bit since then. It's become more compact and smaller and easier to put in from that perspective. But I've not had to do any revisions. Now I have had some revisions on the fusion group.
Okay. Well, we're unfortunately out of time, and there are a lot of questions that are still here. So what I recommend to the audience is, either reach out to Steve's office. This is his office number in Milwaukee. Alternatively, we have a group in Connecticut that fields questions and can follow up. For those who don't want to travel to Milwaukee, we have other surgeons, and you can go onto our website and look at the surgeon locator to find surgeons that are closer to you. But we're aware of patients that have traveled far to see Steve because he's got extensive experience with TOPS and other technologies. And I think that's the nice thing about seeing a surgeon like Dr. Robbins, is that he's so well versed in so many different alternatives that ultimately, when he comes to the conclusion that something is the best, it's after he's weighed all the different alternatives that are available. And so I think that's the one thing that's advantageous about seeing a surgeon who, like Steve, is so involved in looking at many different types of modalities for treatment. So we want to thank you, Steve, for your time, and and hopefully we'll be able to follow up with patients who have more questions for you.